Good. Okay, so let's talk about major trauma in older adults. My name's Caroline Leech. I can see from the people that are on, I know quite a lot of you, which is fantastic. If you're on Twitter and you want to start a discussion, then my username is @LeechCaroline. They didn't have Caroline Leech. I might have a fall less than 2 meters because my cat's behind me on the chair and he's trying to push me off because he wants some more room. So hopefully I'm not in that cohort. I'll be okay. So I am a consultant in emergency medicine working at University Hospital Coventry, which is an adult major trauma centre. And I am also a pre-hospital doctor working with the air ambulance service. And I'm also the major trauma clinical lead of the trust, which is fantastic because I get the experience of seeing patients from the point of injury, moving through the ED, onto the wards and into rehab. And within my role, I've had to think about what are the challenges of looking after this group of patients. So objectives of our talk today is to look at what's the definition of elderly trauma, what's the scope, what are the challenges of identifying severe injuries in this age group, sort of what are the top 4 injuries that we shouldn't be missing, what's the impact of frailty on patients' outcome, and how generally do we improve our care of this group of patients, and that's both pre-hospital and in hospital. And I can see from the people who are on today, we've got a good mix of people from both pre-hospital and in hospital, so it's all relevant to all of us. The first thing I want to talk about is the definition, and you often hear this term elderly trauma used to describe trauma occurring in patients aged 65 years and over. If you picture somebody who's elderly, you think of somebody who's very frail. They've probably got grey hair, glasses, they've got a kyphosis, they walk with a stick or a frame, perhaps they live in a nursing home. But actually, of course, people who are age 65 and over are not like that at all. So I would like us to move away from this term, because when we're thinking about how we treat patients within that age group of 65 plus, it's very different. And it's not about their age, it's more about comorbidities, function and cognition. So I would like us to move away from elderly trauma as a term and move towards the term trauma in older adults. It's not a slick, but I think that is where we should go. But we're going to be doing a lot more work on this as we move forward, and we want to get the terminology right from the start. These are elderly people. They are, well, they're probably not now, but they definitely were fitter than me when they did their achievements. So the guy on the left, he summited Everest at the age of 80. That was his second time that he'd done that. He'd also skied down Everest over the age of 65. And the lady on the right, she successfully completed the London Marathon in 2016 at the age of 88. So these guys are fitter than most of us, and yet they're elderly. So, you know, that's why it's perhaps not a good term to use. This is the oldest current living lady in the UK, Ethel. She's 112. She has been elderly for 47 years, and I'm sure the Ethel at 65 is quite different to the Ethel at 112. And also, if we're going to start saying that everyone over the age of 65 is treated in a certain way, which is different for how we treat younger people, for example, let's do a whole body CT scan on this 65-year-old, because they're going to live for less time than a younger person, their radiation risk is less. But that might not be true if they're going to be living for 30, 40 years more. So I think we need to be a bit more nuanced about how we talk about and how we look after these patients. And of course, the other term that we do use is silver trauma. Again, I'm not sure that that's a very inclusive comment, because again, it sort of refers to hair colour maybe being silver. I think it's okay, but again, perhaps we need to think about, are we using the right terminology for our patients? Is it actually that they're older? Same as we'd say children. These are older adults, and we need to look at the spectrum. So this was the wonderful cake that was made for us at University Hospital Coventry when we celebrated 10 years of being a major trauma centre. And we had 14,000 patients admitted who were TARN eligible during that time. So obviously we looked at all of our data to assess what were the sort of patients that were coming through. Our trauma centre is not probably massively different from any other, although we don't have many trauma units around us. So we are the local emergency department for a lot of patients. It's not that they're bypassing other hospitals to get to us, it's that we are the nearest. So that might be slightly relevant, but otherwise we're pretty standard. So if I just ask you to think about what's the most common mechanism of injury in those 14,000 patients over the last 10 years, well, we're in this certain talk, so you can probably guess what the answer is going to be. But the answer is falls from less than 2 meters. So that is patients who've fallen from standing, they've fallen off a chair, they've fallen out of bed, or they've been up a couple of steps on a ladder and their head has been at less than 2 meters height. So 50% of those patients over the last 10 years had a very low mechanism of injury, fall from standing. Now, as I look at the data, those numbers increase year on year. So is it that our population is getting older? I don't think so. Is it that people are injuring themselves more? No. I think we're actually getting better and better at identifying these injuries. So in the past, we didn't think that falls from less than 2 meters were a big deal. They wouldn't even have been on this list of mechanisms for severe major trauma. Now we do. We're taking it seriously. But also, I think we are detecting injuries better. So we examine patients better and we do more imaging. So in the old days, I would have done no imaging or plain X-rays, and now we're using CT a lot more. So if we look at all of those patients again over the last 10 years, what do you think was the most common age band of injury? And I might catch you out on this one. So if we break them into 10-year bands, what was the most common age band for injury, the most patients in each group? Have a think what you think that might be. And this is the data. So in our data set, it was 80 to 89-year-olds formed the largest group of patients. So have a look at the trends here. So you'll see that as patients get older, there's a general trend of increasing patients until, of course, around the age of 90, there's less patients alive. So that's why that's dropped off. There's a blip here, which is basically predominantly males who indulge in risk-taking behaviour. So drive like bonkers and have car accidents, get involved in fighting and are involved in assaults and obviously violent mechanisms of self-harm. But otherwise, the trend is to go up in a row. You'll also look at the male-female pattern and you'll see that, again, there's more males in all of the age groups until you get to the age of 70 when it evens out. And then women predominate in the 80-plus age groups. So again, why is that? Is it that women live longer? So there's more women around. I'm not convinced by that. Is it that more women fall, or is it that women are more likely to injure themselves if they fall? So again, there's probably a bit of work to do around looking into why there are those differences that might inform better methods of injury prevention. We can also look at the impact of lockdowns. So 2019 are the blue, and 2020, when we had our lockdowns at the front, is the red. And obviously, when we were not able to drive and people were not on the roads and the pubs were shut, there were less vehicle incidents and there were less assaults. And there were also less young people falling from standing when they were drunk. However, the figures for older people trauma falling less than 2 meters didn't change. So predominantly when people fall over, they're falling over in their own homes. It's not when they're out and about. So that's also relevant to think about. So one thing I do call trauma in older adults is stealth trauma, because it's so easy to miss injuries in this group of patients, and we do every single day. We do it in the pre-hospital environment, we do it in the ED, we do it on the wards when patients fall over. So what we need to do then is think about why are they challenging, and therefore how can we get our spider senses working a bit better to spot them. But let's just go through some of the reasons. The first one is this low energy mechanism. I think we've got a lot better at that. So we know, like, if a 4-year-old fell over, well, they fall over like 10 times a day, don't they? And they're absolutely fine. A 44-year-old falls over, they might get a minor injury. An 84-year-old falls over, this could be a life-threatening terminal event. I think we understand that now and we recognise it, but we haven't always. And if I compare a paramedic talks to me about a mechanism of injury for a high energy transmission, so a big RTC, and they show me a picture of a smashed up car, that's sort of much more emotive than was someone just tripped over. So I think that definitely we're getting better at recognising that low energy doesn't always equal benign. The next thing is these patients come to hospital under the radar. So a young, high mechanism of injury, big car crash, that patient will be trauma alerted in on blue lights. There will be a trauma team waiting for their arrival, et cetera, et cetera. The older adult who's had a simple fall will come to hospital, normally by ambulance, normal road speed. They'll come into ambulance triage and get handed over to a nurse. They may not see a clinician for some time. It's very, very different. And then, of course, we've got the group of patients who've come into hospital for medical reasons. They have a fall on the ward and they sustain, again, very severe trauma. But because they are then assessed by a junior medical doctor who might not have had any training in the trauma primary survey, again, those injuries can be missed. So we should recognise where these patients might hide. So it might be the paramedics miss the injuries. They've had a fall. They go to the medical assessment unit. The medical guys are not thinking about injury because the paramedics said they're fine. And you can see very quickly how injuries can get missed. This is probably the most interesting, the anatomical and physiological differences of the older adult. So to start off with, the osteoporosis, they're much more likely to fracture bones with a very low impact. The brain is atrophied, so even a healthy, alert older person, their brain is smaller. The gap between the brain and the skull is wider, and there are bridging veins across that. So if there's a big gap and the bridging veins are stretched and then they have an impact to the head, that will tear the bridging veins and cause them to bleed very, very easily. So very simple, tiny impact and they're bleeding. There's a big gap. So it takes a lot for that space to fill and then squash the brain. So very often patients who've got big bleeds on the brain still haven't dropped their Glasgow coma score. They're still alert GCS 15, even though there's significant volume of blood there because of that space. And someone like you or I with the same volume of blood would be GCS 3 in coning. That's something that we need to think about and be aware of. The older adult may be on beta blocker, so they've got a lower resting heart rate and they won't map a tachycardia if they have any hypovolemia from bleeding. So we shouldn't be reassured by a normal pulse. And then normal resting systolic blood pressure is higher because of atherosclerosis. So an older person with a blood pressure systolic less than 110 might actually signify hypotension. So again, we need to be very careful with how we interpret those signs. Often these patients have got comorbidities. I've got a good story actually from the other day. Went to assess an older lady who'd fallen from standing, and I was going through my trauma primary survey and I said, have you got any pain in your neck? And she said, yes. And I said, oh gosh, okay. She's like, I always have pain in my neck, don't worry. And I said, okay, is this pain any different from normal? And she said, no, it's fine. She didn't have any other neurology. She didn't have any other injuries, but I didn't trust her. I scanned her neck and she had an unstable cervical spine fracture. So don't trust these old people. If they tell you that they haven't got any pain, it's a normal pain for them. Similarly with the hip, they normally have hip pain, they've still got hip pain and they can't walk with it. You'd worry about a neck of femur. And then with the polypharmacy, obviously lots of different medications, but specifically thinking about anticoagulants. Is the patient taking warfarin, a direct oral anticoagulant, or are they taking clopidogrel? Because that will put them at significant risk of bleeding when they might not do otherwise. And then finally, I think it's relevant to say that sometimes that history and examination can be really difficult. So especially if they're immobilised and they can't see very well or they can't hear properly. So think about whether the glasses and the hearing aids are coming with the patient to hospital. It's really relevant. Sometimes they might have some cognitive difficulties. They can't really remember what's happened. So I think it can be more difficult. It can be more challenging to get a proper history and to do a proper examination and get that response back from the patient. So again, we shouldn't underestimate that. So how do we triage older adults with major trauma? So the first thing is that we use our normal major trauma triage tool that we would for any ambulance service. And this is the one for the West Midlands. So if an older adult triggered on stage 1 vital signs or stage 2 anatomy of injury, we treat them the same as anyone else and we would be alerting them to a major trauma centre. If they didn't meet any of those criteria, then obviously you'll be looking at number 3, and you'll see there that it says patients over the age of 65 consider the silver trauma safety net. So that's basically saying we should be considering in older patients that they do have a higher risk of injury. That doesn't necessarily mean they need to go to a major trauma centre, as we'll discuss later, but it means that we probably need to have a lower threshold to consider that they've got severe injury. So let's talk about the silver trauma tool. So this is used by West Midlands Ambulance Service, and this is the poster that we have at Coventry. So this is for patients aged 65 years and over. And if they trigger on one of these factors, and so that's acknowledging that they can be hypotensive with a higher blood pressure, it's looking at specific anatomical injuries and it's looking at mechanisms. And if a patient triggers on this and the ambulance service ring us and say, hello, I've got a silver trauma alert for you, then we will make sure there is a doctor and a nurse ready to receive the patient They don't need a trauma alert, they don't need necessarily a consultant, but they are seen very promptly on arrival, because we want to really try and get them out of immobilisation as quickly as possible, and we want to get some imaging done as quickly as possible, and we want to make sure that they are well analgesed, and where we can, we want to get them up and about as quickly. So we've done some local audit on this data, and we only get 1 or 2 patients a week, which suggests to me that we are underusing this tool. We're probably under triaging a little bit. But of those that we do get, the most common reason is fall downstairs. So an older person who falls top to bottom of the stairs, that is a massive red flag sign. And for the majority of those patients, we would perform a whole body CT scan to exclude injury. Around 80% of patients that are alerted as a silver trauma alert by West Midlands Ambulance Service need to be admitted for their injuries. So it is a useful tool. We haven't properly tested the sensitivity or specificity. That's something that I think as trauma networks, we all need to probably consider and look at. So this is sort of another learning point that I want you to take away. Every single person you see that's had a fall, I want you to do a full trauma primary survey. The sort of trauma primary survey you would do on somebody who'd been ejected from a vehicle. Because we know that for an older person, that even just a fall from standing can be significant. So do your A to E assessment. Of course, airway's probably fine. Check the cervical spine. Check for rib fractures, so palpate the chest. Check the abdomen. Check the pelvis and the hips, the neck of femur. Check the femurs. Then obviously thinking about disability, you want to have a look, is there any external signs of head injury? You want to check the thoracic and the lumbar spine, and you want to see if they've got any neurology, so power and sensation in all 4 limbs. And then thinking about E, have they got any limb injuries? Now, if you do that for every single fall, then hopefully you will not miss any injury at all. So the other thing that older adult falls need is, we've talked about ruling out injury with a trauma primary survey, but we also need to think, is there a medical cause for the fall? And really commonly, I hear the term mechanical fall used. I think if we asked everybody on this webinar, we've got 566 people, what do you think is meant by the term mechanical fall? We'd all say something different. So what I want to hear is the actual what happened. So did this patient trip over the carpet or trip over the cat? Did they stand up, they felt a bit dizzy, and then they fell over? Was it that they got up from the toilet and their knee gave way, and then they fell to the floor? Because each of those is very different. So if there is a medical cause for the fall suspected, it wasn't a simple trip or we can't explain it, then obviously we need to think about excluding other things. So I would hope that in the pre-hospital setting, we'd do a blood sugar, and we'd also do a 12-lead ECG. And then obviously in hospital, we'd consider other investigations, including bloods, etc. And then the third thing that we just need to think about, and particularly more and more at the moment, is has that patient been on the floor for a long time? Obviously worrying about the risk of rhabdomyolysis and then an impact on their kidneys. So we'd want to think about rehydrating the patient. And we'd probably want to measure a creatinine kinase as well as a usinase, just to have a look if that's affected them at all. So I don't really know what's a long time. I think, that's a good question. I think if anyone's got an answer to that, tell me, but really just to use your common sense about what's a long time. So for an older person, probably anything over an hour is maybe significant. And I think with the delays to ambulances getting to patients in the community, we do need to think a bit harder about how we might educate relatives and carers to perhaps try and get patients up if they appear relatively uninjured, or can we use telemedicine? And nursing homes where they don't get their patients up off the floor, we probably need to do some work around that as well, because this is obviously pathology that we could prevent. So these are what I think are the top 4 areas that older adults injure. So their brain, their spine, their ribs, and neck of femur fractures. So if you do your full trauma primary survey on every patient that you see, older adult that's fallen, and then just have a think, did I properly check the head, the spine, the ribs, and the hips? And if you do that, that's almost like a double check. And when my juniors are presenting cases to me, I will say to them, did you do your trauma primary survey? Are you happy with the head, spine, ribs, hips? And that's our sort of little checklist. So let's go through each of those in detail. So we've already talked about the brain. We've talked about how there's those bridging veins that are more likely to shear because the gap's bigger, that they will drop their GCS a lot later than younger patients. And we're going to be aware of that when we're triaging. But actually, the management of head injuries is fairly simple in that we're going to use the NICE head injury guidelines. And really exciting, these are going to be updated early next year. So January, February next year, we're going to get the new NICE head injury guidelines. And I am really interested to see how they approach anticoagulation. So most of our older patients don't meet the initial criteria, but they are quite frequently on anticoagulation. I would worry about warfarin. I'd worry about clopidogrel. I'd worry about direct oral anticoagulants, like that's the rivaroxaban, apixaban. I wouldn't really worry about aspirin at all. But certainly in my trust, and probably in many of yours, we are scanning nearly all of these patients and the scans are coming back negative. So we're just doing it for the only reason they're asymptomatic, they bang their head and they're on anticoagulants. This is an area that hopefully research will inform what our practice is in the future, because we really need to cut down on probably some of these CTs. The other way that they'll trigger is they've had loss of consciousness, and that's like a proper loss of consciousness, not a few seconds, we're talking about minutes, or amnesia since the head injury, and their age is at or more than 65 years of age, then that patient will also need to have a CT scan. So we're going to use that to triage our head injuries. So we can use that to decide if someone definitely needs to go to hospital, if there's no other reason, and we can use it to decide who needs urgent CT scanning. We also, in hospital, and maybe sometimes pre-hospital, need to think about how we would reverse these agents. So if an older patient is taking warfarin, or they're taking a direct oral anticoagulant, and they have a head injury and they have a bleed, it may be that they're not going to be suitable for any surgery, they're not going to be suitable for ITU. So actually stopping them from bleeding is absolutely critical. This is a time-critical intervention. And what I want you to do is, if you work in an emergency department, think, where do I keep these products? Have I got them close to hand? Can I get them as an emergency if I needed to? Because for an older adult, it may be the only thing that you've got to treat them that's going to make a difference. So for patients on warfarin, we reverse that with 10 milligrams of vitamin K IV. And we also use this, we've got Octaplex, you might have Beriplex, which is a prothrombin complex concentrate, either based on their last INR or a generic figure. And on the right-hand side, we've got reversal of a DOAC. That would be tranexamic acid 1 gram. You're not giving that for crash 3 reasons or crash 2 reasons. You're giving it just to indirectly reverse that DOAC. And again, you'd give the prothrombin complex concentrate. There are, of course, some direct reversal agents, but they're very rare and they're often very expensive. So have a think, do I know how to reverse these? Do I know where the guideline is on my hospital e-library? Can I get hold of them quickly if I need to? The crash 4 is running at the moment in a number of emergency departments and ambulance services, and it's worth knowing about because this could change management. That's what I said about there's not much that we do for some of the older head injuries who are very frail. So this is patients 50 or over with symptomatic head injuries, not any head injury, symptomatic. GCS is 13, 14 or 15 and head injury in the last 3 hours. And these patients are going to get an IM injection. We don't know if it's tranexamic acid 500 milligrams or a placebo. And then we're obviously going to follow them up, see what the CT scan shows, because not all of them will necessarily have a head injury. And then obviously see what the outcomes are. So this is a very exciting project. So a couple of years' time, we're probably going to get the results for that. That could change obviously what we do, both in the pre-hospital setting and in hospital. So that was the first one. Don't forget injuries to the head and the brain. The next one is the spine, and it's the cervical, thoracic, and the lumbar spine, but we do treat them a bit different. So cervical spine is one, thoracic and lumbar is the other. And one of the things that we really need to think about in the older patient is their mobilisation. So we think that they are high risk. We think they might have injured themselves or broken the neck or whatever. Here's the traditional mobilisation in the picture: a scoop structure, head blocks, collar. Don't think it's a very well-fitting collar. But maybe that's not the best thing for the patient. So we need to think pragmatic immobilisation in older adults. It might be they've got COPD and they can't lay flat. It might be that they actually aspirate when they lay flat. It may be that they have a severe kyphosis and you can't get a collar on, and they actually need loads and loads of padding under the head. It might be that you need to sit them up in a semi-recumbent position. It might be that you don't want to put head blocks on because they can't hear a thing. So whatever you decide, you need to make that risk-benefit analysis, and you need to clearly document it so it's obvious to anybody reading the notes. Why did you decide to immobilise as you did? And what was your risk-benefit analysis? But what we can't do is strap down old people to boards just, because that's what we need to do to be safe and avoid litigation. We need to be pragmatic. This is the Canadian C-spine rules, commonly used to decide on whether or not you can clear someone's neck, or whether or not you need to use radiology, which in essence for older people, you're going to have to do a CT scan of the cervical spine, because there's so much degeneration on a plain x-ray, you will never, well, unless you're very good, work out what's going on. There's a problem, because if you look top left, being older automatically makes you high risk and means you need imaging. There is no way I could image every single older adult who comes to me with a fall. My CT scanner would just be full of those patients and nobody else. So how do we, sort of triage these patients appropriately? And this is what I do, and it's not evidence-based, and don't necessarily use it in your practice, but interested to see what other people do. So the Nexus guidelines are there. So the patient needs to have no posterior midline neck tenderness. They obviously can't be drunk, they need to be alert. No neurology, so you've checked for power, tone, sensation, reflexes in the limbs, no distracting injuries. And then I add something onto that, and I add any suggestion of neck pain, thinking about the last case that I described to you. So any neck pain at all in an older adult, and they've had a fall, then I would consider imaging their neck. If they have zero neck pain, zero tenderness, no neurology, they are alert and orientated, and then I ask them to move their neck and it's pain-free, well, that for me is cleared, because I can't CT scan everybody over the age of 65. Be interested to hear what other people do. So the thoracic and lumbar spine are quite different. So again, tiny mechanisms of injury, and these patients will get osteoporotic wedge fractures. And as long as the loss of height is less than 50%, they're normally stable. And these primarily we can image. If we're not doing any other imaging, then I would go for a plain x-ray first, because it's just done really quickly. And from then we can decide, does that look unstable or not? Does it need a CT scan? And obviously we will have assessed neurology anyway, to see whether or not we needed an MRI. So very, very common in our older patients. And it can even be stuff like they've just bent forward and they've given themselves a wedge fracture as well. This is one thing that another thing I want you to take away from today, because I've seen a few cases where this has been missed. So an older patient is found on the floor after a fall, and they have some neurology to their limbs. And the assessment is that they've basically had a stroke, and that's what made them fall over. So had a stroke, fallen over, laying on the floor, now have neurology. This older adult actually has degenerative changes of the neck, which means that when they do that, they've squashed their spinal cord, and bruised. It's a really strange pattern of neurology. So the arms are totally paralysed and have no sensation, but the legs are kind of like a bit weird. So there is some sensation in some areas and not in others, and the power again is quite random. So if you see a patient, they've got neurology, think, is it actually central cord syndrome? Have they actually injured their neck? And do they need an MRI? And often these patients have a normal CT, as in they don't have any fractures. It's literally been that when the spine moved, it crunched the cord and has bruised it significantly. Now, these need to be treated like any spinal cord injury. So the same as your motorcyclist who's got a level, and paralysed, the older adults as well need the same sort of level of care. So this should be discussed with a major trauma centre. This should be referred to spinal cord injury centres and have all the care that goes with that. So don't miss that one. Right, we're on to ribs. And the one big thing, most common injury, I think, that is missed pre-hospitally in older adults is rib fractures. And I think that's because we don't expose them and we don't palpate properly. So you've got your clavicles, your sternum, you've got your anterior ribs all the way down, your lateral ribs all the way down, get your hands behind, posterior ribs all the way down. And then if there's pain-free, just spring the ribs gently and see if there's, again, any referred pain at the back. We don't really do that. I see a lot of people just go squidge, squidge. No rib fractures, they're fine. So proper examination. Chest x-ray has a sensitivity of about 50%. There's been lots of patients I've seen who were had a chest x-ray, then had a CT. CT showed millions of rib fractures. Radiologist has gone back and looked at the chest x-ray. There are definitely no rib fractures on the chest x-ray. So don't use chest x-ray to rule out rib fractures. So what we do at Coventry is non-contrast CT scanning, because that will enable us to detect the rib fractures, and most of these patients are low risk for lung injury. So they don't have significant pneumothoraces or hemothoraces. If the scan did show suspicion of that, we might go on and do a contrast scan instead. But the sorts of patients that we would select would be over the age of 65, tenderness or severe bruising over 3 or more ribs, and despite having decent analgesia like morphine and paracetamol, they still can't breathe properly and they still can't move properly. So their dynamic pain score is still high, because these patients are going to need to come in for analgesia. So we need to know, do they definitely have rib fractures, and who do they need to come in under? So wherever you work, and this isn't about major trauma centres, this is about all of our hospitals. We are all seeing these patients coming in with rib fractures every single day. You need to have some sort of algorithm for how you're going to manage their pain, acknowledging that you can't always use non-steroidals. You can't always use things like gabapentin. They are very opiate sensitive. They may have renal problems. So our practice would be that to consider early nerve blocks in these patients. And so again, wherever you work, just explore if you have an older adult and their pain's not controlled on standard analgesia, what means do you have to access your GT anaesthetist, for example, for nerve blocks, and which of your wards can receive patients with nerve blocks as well. And should say as well that analgesia starts in the pre-hospital setting. So if you are a paramedic watching this, please do not undertreat your patients, because as you know, they are probably going to be waiting quite a long time to see the doctor. So if you can start their analgesia early to make sure they can breathe and cough right from the word go, then that's really important. So again, lots of patients coming in with rib fractures every single day. We are not going to be referring these all to a major trauma centre, and they don't need a major trauma centre. What we're going to do though is work out who they are going to come in under. So I've got one trauma unit in my area that they come under trauma and orthopaedics. I've got one where they come under general surgery. And in my major trauma centre, actually, most of these patients are coming in under medicine. So if they've got no significant lung injury underlying, the rib fractures are not suitable for fixation, then we would admit under medicine. But to do that, you have to have a system around medicine to support them. So these patients need decent analgesia and input from the pain team and nerve blocks. They need chest physiotherapy, which can be provided by any physio on the wards. But do they have access to that? Early mobilisation. If they are in a trauma centre, they would need referral to the trauma service. And really importantly, thinking about bone protection and delirium prevention. So they're things which we might often miss when we're just thinking trauma, but these are really important things for these patients. The fourth injury I've got on my list is a neck of femur fracture. And going back to sort of these patients who've got hip pain, but they can straight leg raise, or they don't have any massive groin tenderness, they're really easy to miss. So in ED, if you've got somebody complaining of hip pain, I would just get an x-ray. And of course, if that x-ray is inconclusive and your patient's unable to mobilise, more and more commonly we're doing CT scans to exclude injuries. And actually surprising how many we do pick up. So that was your 4 injuries: your brain, your spine, your ribs, and your neck of femur fractures. So again, if you work in hospital, I've mentioned that patients are falling on the wards, they're sustaining significant injuries, and these are sometimes getting missed. And we've had a few incidents in my hospital where that's happened. I'm sure it's happening in other hospitals as well. So have a think within your systems, are there things that can help the medical teams that are reviewing these patients? So I know some trusts have got almost like a mini SWAT team that come and review that patient on the ward and do a primary survey. But actually, we could just empower doctors who are reviewing those patients by having a pro forma. So you have a falls pathway that guides the doctor through what they need to check. And it can be part of their induction training, and there can be just a video perhaps that they watch. But I think if nurses and doctors are really aware of this from the word go, then again, we're going to pick up those missed injuries that are currently occurring. So some questions really like, how are we going to adapt to cope with this increasing burden, I often hear it called, of older adults who have this low mechanism of injury, who've actually got really severe injuries and compromises their performance. Do these injuries actually need MTC level care? Well, the majority of older patients, so the frail ones, will not be for surgical intervention, thinking about the heads and the spines. They're not going to be for ITU. They're probably not going to be for CPR. Many of those injuries that we've talked about can be managed in any hospital, but definitely can be managed in a trauma unit. So when we're looking at it, what do they need and what can be provided? And we probably need to upskill our trauma unit so that they can look after these patients. Do we need to be blue lighting in falls less than 2 meters? Probably not. So do they need time critical imaging? Well, they don't need a CT within 30 minutes, which is the quality indicator that's often given. But actually, as I've said, it's really important to get them off immobilisation and to get them sorted and to get them up and about if we can as quickly as possible. So I don't think they need to be blue lighted in, but they do need to, when they get to the front door, be seen by a senior decision maker and prioritised for imaging and intervention. How do we prognosticate in older patients? So I've sort of said before, we can't write off everyone over the age of 65, but what sort of tools can we use to decide on whether somebody is appropriate for more advanced interventions? And who looks after these patients in hospitals? We've already said with ribs, it could be the surgeons, it could be trauma orthopedics, it could be medics, it could be cardiothoracics. Wherever we work, we need to have pathways in place to make sure there's not a fight every day in A&E working out who's going to take the patient, and that there are no delays in making decisions and getting them sorted. More questions than answers, sorry. So it's really important to talk about frailty, and you've probably seen this. It's a Rockwood score, clinical frailty scale. And essentially, if you're score 1 to 4, you're not frail, and 5 plus you are. And obviously, the worse, the more frail you are, the higher scale that you are. So this was a study that was done and published last year. It was done in one major trauma centre in the UK, I think it was Bristol, and they looked at 300 consecutive older patients coming through, and they recorded a clinical frailty score regardless of how severe the injuries are. So normally you only have to do that if ISS is greater than 15. They did it on everybody. So 1 to 4, remember, was the baseline, not frail. And what they found is if you had a clinical frailty scale of 5 to 6, you had 5 times the mortality and twice the need for increased care level at discharge. So this was significant. And if it was 7 to 9, that's obviously a much frailer patient. They had 10 times the mortality. So frailty can be used to predict adverse outcomes and possibly to consider whether or not you would provide more advanced interventions for patients and surgery, etc. There's a lot more work I think we need to do on this. And again, clinical frailty scale in major trauma, it was used in best practice tariff. We're currently on a block contract, but that is basically that all patients who are 65 years or over are seen by a geriatrician within 72 hours of admission. And I was pleased that they put that in because it allows places to develop services where you do have a geriatrician going around, much like they did with the NECA-FEMA pathways. They had ortho-geriatricians on the wards. But do we need that? Or do we admit patients under medical doctors? We admit them under the geriatricians primarily with the surgical backup to look after them. So looking at it from the other way. The medical teams are absolutely on their knees. But actually, if I look at it, I think that might have the best outcomes for our patients. So thinking about the future. So nearly at the end now. So what are some future thoughts for us? So do we need to expand our definitions? So when we say older adults as a big, massive group, do we need to further define what we mean by older adult? Thinking about the massive range of patients that we've got within that. Do we need to do more research into triage tools for older patients? So how do we identify those that would benefit from an MTC level care? How do we identify those that might benefit from being triaged more quickly and into the hospital and through the system quicker? We've got the new NICE guidelines coming out for head injury, which will be interesting. Wherever you work, we need to think about pathways for those older patients with traumatic brain injuries that are not for ITU and not for surgery. The same for spinal fractures. and the same for rib fractures. So these are three sort of groups of patients that won't necessarily need to go to the major trauma centre or to the surgical intervention, but do need pathways of care. We need more pragmatic decision making. So an older patient with an unstable fracture of the cervical spine is not appropriate to be on bed rest for the next 6 to 8 weeks. That's just completely inappropriate for that patient, particularly if they're coming towards the end of their life. So do we need to be having discussions with the family and the patient, if that's appropriate, and basically discussing these are the risks, these are the benefits. I think basically we need to get you out of bed, get you moving with a collar on, because I think your outcome will be better and you're going to have a better quality of life. Excuse me. And then finally, my gold standard, I think it would be amazing if we could have, and it says there elderly care, because that's what it's called in my hospital, but these would be elderly care major trauma wards. So they're for the frail patients who are elderly, who are looked after by geriatricians, with nurses who are competent in surgical stuff as well as older adult care, and backup from the surgeons visiting for advice if needed. Got a frog in my throat now. So that's all from me. Probably lots of questions from you, and also be really interesting to hear some of the things that you've been doing. I'm going to stop screen share and I'm going to hand back to Anna.
Brilliant. Thank you so much. I think, well, first off, just straight from the word go with that webinar then. I think I'm going to put it forward to Sir Keith, if he's in the chat. I haven't actually seen him pop up tonight, to change the name of the Silver Trauma Programme to TOPS, because as someone rightly pointed out, they are 31 years old and going silver. I'm 29 years old and have lots of grey hairs. So I don't think Silver Trauma is quite the right name for it. So as I said, we shall be changing that to the TOPS programme for the Wednesday of the conference. And yet we definitely have had a few questions come in. One of these questions, and I'm going to share my screen again, just because one of the questions very quickly related to tonight's certificate. And that was basically asking that they're not a trauma care member, how do they get a certificate? This is how. You can see the QR code on the screen now. If you scan that, it will take you through to a type form, which you fill out. You pay £1.99 and you'll get a certificate sent straight through to your inbox. If you are a member, please don't scan that code. Your certificate will be sent to you tomorrow automatically. So we've had a couple of questions come in. So I'm just going to start from the top and roll through them. So from Suzanne, how can we avoid over or under triaging? Do you use a tiered trauma call system?
Yeah, so if older adult triggered the trauma triage tool, the traditional one that you use, they've got deranged physiology or significant anatomical injuries, then we would treat them like a normal trauma alert. The sort of silver trauma, as it's called, alert is just one doctor and one nurse waiting for the patient to arrive. So that is very different. That is a tiered system. I think, though, the answer is we don't know, is it, how to over or under triage? We often get it wrong. That would be a fantastic area for research in the future, wouldn't it? How do we better identify which patients are severely injured or not, and which need a more time critical response rather than a sort of normal, lazy ED response?
Wonderful. So the next one comes from an anonymous attendee. So they work in a region that resounds to airports. They have a lot of mechanical floors and escalators involving suitcases and whatnot. So a lot of the time their patients are advised to go to hospital for full assessments, and many refuse because they don't want to go on, they don't want to miss the holiday or their flight. What advice have you got for this attendee about how to sort of handle these situations and convince the TOPS patients to go?
Yeah, so that's really high risk, actually. Falling down an escalator, I've seen some absolutely devastating injuries. So it is really high risk. I'm assuming that you may be a paramedic type of responder. So you will do your full trauma primary survey to identify any significant injuries. And obviously then that will guide your information that you give to the patient about the likelihood of them having an injury. At the end of the day, if they've got capacity, of course, they will make that decision for themselves, but you might want to reflect on them that being treated in a country abroad may not always go very well if they do have an injury. I think you can understand where they're coming from, but I think the biggest part for me would be you do a really good trauma primary survey and then feedback to them what your findings are. And then obviously it's up to the patient if they will have capacity, they're at the airport.
Wonderful, thank you. Just a quick note, guys, if you do want any questions answered, please pop them into the Q&A, not into the chat, because the chat's flying up at the moment, so I will probably miss them. So just pop them into the Q&A box instead, and I'll make sure to try and get around to them as best as I can. So the next is another anonymous. What imaging is better for neck fractures, X-ray or a whole body CT scan?
So for an older adult who has a low mechanism of injury, so fall from standing, and I'm worried about the neck, I would do a CT of the cervical spine. I would obviously, if I'm doing a CT head, because they meet the NICE head injury guidelines, I would also think carefully about whether or not to add on a neck as well. So if I've done a full body trauma primary survey, the only thing I'm worried about is the neck, I will do focus imaging CT of the cervical spine.
Okay, it's wonderful. And this is a bit more of a panel discussion kind of thing, I guess. From Ashley, I agree with the idea of a possible falls pathway for nursing homes, so they reduce the amount of calls made to the ambulance service. I would like to know your thoughts on this, Caroline.
Yeah, so one of the problems that we've got, and this is across the whole country, is I think some of the nursing homes are often staffed by locum staff. We know that social care is in a lot of difficulty at the moment. And the staff say that they're not trained to get somebody off the floor, and they don't have the equipment for it. And therefore, these patients are left in a nursing home on the floor for a very long time, waiting for an ambulance, of course, which is no fault of the ambulance service. So I think there's been a project locally where they identified the top offending nursing homes, as it were, who were calling them for fallers. And they then educated those homes and provided them with some equipment, which would, of course, save significant morbidity for those patients. So that would be, I think, a fantastic, project intervention to do. Nursing homes are always going to call you. They're always going to call the ambulance service, unfortunately. So the next thing is, should we have perhaps, I know some areas with specialist paramedics are doing using a specialist paramedics to go out and assess these patients quickly. So one paramedic on a car going out, picking the jobs off the CAD where they can actually make a big difference by, with the carers there, get them up off the floor, examine them for injury, and maybe stand down an ambulance crew.
Wonderful. Thank you. So I can see now I've said that questions are coming flying into the Q&A. So I will say now, guys, two things. One, as I mentioned, I'm not medically trained. So if I do say something and you all start sniggering behind your screens, I do apologize if I say it completely wrong. Two, we might not be able to get around to all the questions tonight because I think there's 14 open questions at the moment. So fortunately, I might not be able to get around to them. But if you do want to have anything answered, as Caroline said before, she has got a Twitter handle, and you can always email into the office as well. And I'll do my best to send them off to relevant people to get them answered for you. Oh, this is quite a good one, actually, from Neve. Have you found there are any specific injuries in elderly trauma that pre-hospital clinicians often miss?
Yes, so the top injury they miss is rib fractures. I think they are sometimes reluctant to expose the patient fully. They can sometimes miss significant bruising and not palpating the whole of the ribs. So just doing a quick press on the front, that's obviously not going to detect all rib fractures.
Okay, so I'm just running through the questions here. I do apologise, I'm not wearing my glasses either. So oh, wow. Okay, so there's loads of questions there. So I think the best thing to do now, just because we are slightly running short of time, is if you guys do want to email them in, you can email admin@traumacare.org.uk. I'll download these questions as well, and I'll do my best to sort of get them sent out to different practitioners and clinicians within this area to get them answered for you, and to Caroline as well if she's got time, because I understand obviously everyone is very, very busy at the moment. I'm sorry, I've kind of put you in it there saying you're going to answer these questions, but if you can't, don't worry about it. So thank you so much for all the questions, guys. I'm going to download all these and get them sent off, as I said. So don't worry, they will be answered, just maybe not tonight, because I'm just going to shoot on with the webinar, just so people aren't hanging around in case you've got places to be. So Secondly, so the second to last thing, obviously support the charity. Please do, guys. You can scan the QR code on your screen now. That will take you through to our charity shop. I know the pictures aren't the best. I am in the process of updating them at the moment, but you can get things like the awesome hoodie that I'm wearing. And if you are coming to the conference, as I said, we have got the TOPS program on the Wednesday. It'd be cool to see loads of people wearing the hoodies and all the different gear. We have got a merch stand there as well, and we're updating our shop as we speak. Tracy and I working very hard behind the scenes to get some new gear in for us. So you can get that hoodie, you can get tops, you can get, and every single thing that you buy comes with a free gift as well. And it's a very cute gift. You can also get the pre-hospital manuals that have been written by Sir Keith and Ian, and a few other people have bobbed in for all of those. There's loads of editions available. Scan the QR code and go through to the shop. The applications to run for trauma care at the London Marathon are open. I know we said the express of interest was closed last Friday. We have had a few people kind of come in and then drop out again. So we are reopening the applications. So if you do want to run for trauma care, doesn't matter your age, doesn't matter your fitness level, it'd just be awesome to see people out there running on behalf of trauma care. Scan that QR code now, or you can email admin@traumacare.org.uk and Tracy will get back to you next week with an application form. And of course, as always, we have to thank our sponsors. Again, you can catch all these guys coming to the conference in October. They are hosting, my frog in my mouth as well, apparently. They are hosting breakfast sessions this year as well. So they're going to be starting at 8 o'clock, running to 9. You can come down early, grab yourself a free bacon butty, free cup of coffee, and have a breakfast session, which is going to be networking, a bit of learning. I know that Galen are hosting one this year. So Galen, they are the people behind Penthrox. Again, we have a Penthrox webinar in September too. The first line emergency analgesic. I think I said that right this time. So that is your analgesic inhaler. And these are the terms and conditions behind it. I'm not going to read all of that because we haven't got an hour. Our other sponsor is Safeguard Medical with water gel. So you scan the QR code there, you'll be taken through to the lovely Andrew, who will be giving you a version of the burn story. And if you scan this QR code, it'll take you straight through to Safeguard Medical's website, or you can go to their website, which is at the bottom of your screen now. Icarus, the power of health. And if you scan that, that'll take you through to their website, our lovely sponsors. We've also just brought on World Extreme Medicine as another new sponsor. So thank you very much to you guys. We look forward to having you on board. And I think with very much finishing on time, that is the end of it. So I'm going to stop sharing my screen. As I said, if you do have anything that you want to ask, please do email in. I've seen in the chat as well. I'll send this out and I'll give a tweet out to it. Thank you to someone who shared it was a research paper as well. So I'm gonna tweet that out for you guys as well. So thank you, Sarah, for sharing that. Loads of things have come into the chat saying thank you very much. So I think that's all that's left to say. Thank you very much, guys, wherever you are in the world. I know we've had people from all over. So thank you. Enjoy your evening, your morning, your cup of coffee, your beer. Personally, I'm going to go watch England win at the Euros right now. So thank you. Goodbye from me. Goodbye from Caroline, and good night all.